Next slide, please. Next. Somebody has to do it manually, I believe, from his. This is not working, sir. No, no, from their master it is a problem. Yeah. So I think we will adjust, no problem. We will adjust. I will tell him to do the next slide. You just sit. Dr. Bharat will be helping with that. So greetings from Apollo Hospital. We are a 1100 bedded tertiary care hospital. So till now what was happening was, once they say the cancer has spread to peritoneum, that means it was the end of the world for the patient. No, that's not the story any longer. So peritoneal carcinomatous earlier was considered curable and there were very dismal survival rates. But after the advent of this HIPEC, there is an improved quality of life and survivability of patients has improved, so that even 10 years survival of the patients of CRS with HIPEC and CRS alone, there is 80% survival rate for 10 years in those patients who are undergoing CRS with HIPEC. So the perioperative management here is very complex because a great deal of fluid changes are there and there are too much blood losses, there is temperature variations and a great deal of hemodynamic stability. So anesthesiologists play an important role in HIPEC and CRS. So what is HIPEC? Each word has its meaning. HIPEC is basically a hyperthermic intraperitoneal instillation of chemotherapy, which is very highly concentrated at a temperature range of 41 to 43 degrees. This is very important. 41 to 43 degrees, which is delivered directly to the abdomen during the surgery. So CRS has, first component of this process is CRS. CRS is basically a cytoreductive surgery, which is a debulking surgery. All the tumor is removed and isolated omentectomy is done. There is complete resection of gallbladder, spleen, right colon, and peritonectomy is done right from the liver surface to the pelvis. So what was the rationale behind that? So the rationale is that peritoneal surface malignancies have two components. One is a macroscopic disease, another one is a microscopic disease. So we treat the macroscopic disease by surgery and the microscopic disease by HIPEC, and that results in improved outcomes. So high concentration of this cytotoxic drug in local tumor bearing area, what it does is basically it kills the tumor locally without having any systemic effects of the chemotherapy. Also, the additional benefit is that since the peritoneum is drained through the portal veins, they carry the cytotoxic drugs to liver, which ensures that even if there are small hepatic micro metastasis, even those cells are killed. So here one thing is very important to note, that this chemotherapy cannot kill tumor cells more than a depth of 5 mm. So any residual metastasis or tumor should not be more than 5 mm of the size. So adequate cytoreductive surgery should be performed before installation of the drug. So as I told you, hyperthermia, the range is very important. More than 43 degree will be detrimental, less than 41 degree it will not work. So what is the mechanism basically? There is non-selective inhibition of RNA synthesis leading to mitotic arrest. And there is an acidic microenvironment is created which leads to the death of the malignant cells. So basically in a flow chart I can explain like this. It inhibits RNA synthesis, there is acidic environment, there is lysosomal enzyme changes leading to cell death. So what they found out, Paul Sugar-Becker found out that heat and cytotoxic drugs, they act synergistically. There is an increased drug uptake in malignant cells by improving the membrane permeability, and which changes the pharmacokinetics and pharmacodynamics of these chemotherapeutic drugs, making them more effective. So, but before going for HIPEC, see HIPEC, CRS, they are very costly. One therapy costs you around 8 lakhs, right? So you should have a suitable candidates for HIPEC. You can't initiate HIPEC in all the cases. So appropriate patient selection is very important, as if the disease is too advanced, there are no benefits. So what are the screening parameters? The screening parameters are preoperative cancer index, which is a radiological marker. I will explain to that. histopathology of tumor, how invasive it is, pre-op CT scan for extra-abdominal spread to rule out thoracic and pelvic spreads, and completeness of cytoreduction score after CRS. Next slide. So as I told you, preoperative cancer index. So this is, the patient is assessed in the OPD itself. Abdomen and pelvis are divided into 9 regions and intestines are divided into 4 regions. See, this is very important for the anesthetist also, because once you know the surgical part of what procedure you are carrying, you gain respect in the OT and you can dictate your terms, and there will be like a cohesive team working for the benefit of the patient. So the scores are assigned 0 to 3. 0 means lesion size is 0. Lesion size 1 is tumor size less than 0.5 centimeter. Lesion size 2 is tumor deposit 0.5 to 5 centimeter. Lesion size 3 is tumor deposit more than 5 centimeter. So this PCI score is between 1 to 39. Any patient scoring more than 20, HIPEC is ruled out. So this is how we do it. This is the radiological screening. This is done before the patient is taken for HIPEC. So this score is very important. So many a times we take the patient for HIPEC, but we have to abandon it if the cytoreduction is not complete. So patients are accordingly counseled that after the surgery is over, the first part is over, we will reassess the patient in drop, and then only we will initiate HIPEC. So completeness of cytoreduction score is based on visible tumor left after cytoreduction. CC is 0, CC1 is less than 2.5 mm, CC2 is tumor between 2.5 to 2.5 centimeter, and CC3 is tumor nodule more than 2.5 centimeter. So obviously CC0 and CC1 are the ideal candidates for HIPEC, as chemotherapy I told you doesn't permeate more than 5 mm. So historically it all started in 1990 with Paul Sugar-Becker describing the PCI, and now the latest is lab enhanced HIPEC technique is described in the literature. Next slide please. So as I told you, when we select the patient, we should have good performance status of the patient. Age should be less than 70 years. There should not be any extra-abdominal disease. The residual lesion should be less than 2.5 millimeter, and there should not be any active cardiac disease. So there are 3 parts for this procedure. One is the exploration. So it all begins as a midline laparotomy, full length incision, and we evaluate where exactly the tumor is and how big are the tumor nodules. And then the cytoreduction or debulking is performed, and then we instill the chemoperfusion. So there are 3 stages in this procedure. So can you play the video, Bharat? Okay, so this is what is happening here. So they are performing the peritonectomy, which is a basic step over the liver surface, right? Next please. See, whenever you are providing anesthesia, you should look at the surgical steps. So you are more confident in what stage the procedure is. So HIPEC techniques are described as 3 techniques basically: open abdomen technique, closed abdomen technique, peritoneal cavity extender, and semi-closed technique. So PC is not used routinely nowadays. Either we go for open or we go for closed. Next. So basically this is an example of a closed technique where a midline incision is given and the drains are inserted along with the temperature probes. This is the closed technique. So once the cytoreduction is done, the tubings and the temperature monitor probes are put, and then the abdomen is closed and the chemotherapy is instilled. Next slide please. So as I told you, what is the advantage? Abdominal wall is manually handled. See, you have to shake the abdomen after the chemotherapy is inside so that it penetrates all the quadrants of abdomen. So larger volume of perfusate is generally done, which increases the intra-abdominal pressure and resulting in increasing permeability of the chemotoxic agents. After perfusion, this abdomen is reopened and perfusate is evacuated. So what are the advantages? There are minimum heat loss. See, what is important? Here one thing is very important. Till the temperature of the abdominal cavity is 41 degrees centigrade, only then it will be effective. So what is the advantage of closed technique? There is minimum heat loss. Hypothermia is easy to achieve and maintain because the abdomen is closed, and there is minimum exposure to aerosolized chemotherapy. See, whenever HIPEC is happening, it's very, very dangerous for even the OT personnel who are working inside, even the anesthetist, because the chemotherapy gets aerosolized. So you should always wear N95 mask till this procedure is going on. But what are the disadvantages? So we cannot there is no even distribution of the drug, and sometimes there is pooling and accumulation in the dependent part. Also, post-op ileus and bowel perforation incidences are more. So, can you play this video with the sound off? I think this is important for the presentation. Just click on it, Bharat, it will play. Okay, no problem. So the next slide, basically, I'll show. Next slide, please. Okay, so what is open technique? Open technique is basically a Coliseum technique where the infusate is maintained at 43 to 45 degrees. Since this is an open technique, we have to increase the temperature and make sure that the temperature is maintained at 41.5 degrees. See, this ensures even distribution of temperature and chemotherapy drug, because you can manipulate the drug inside the abdomen because your abdomen is open. So you basically wash the intestine and wash the abdomen with an open technique, and this allows the manipulation of fluid and bowel for optimal distribution of the drug. Next, please. So this is what is an open technique, right? So this is a retractor and the abdominal wall is sutured to that, and this is where the chemotherapy is instilled. So manual steering of the perfusion is done, but the problems or the drawbacks is technique may be compromised and there may be suboptimal exposure. There is a risk of spillage. I want to tell you, this chemotherapy drug is so toxic that even if you are not wearing the impermeable gloves or gown, it can go through your skin also. So you have to be very careful when you are using the open technique. So a HIPEC model was proposed in which they will cover it with IO-bag and a small hole is left. So this is a hybrid model. This is what is called semi-closed technique. Many surgeons are now going for this semi-closed technique. Next, please. So what are the anesthesia implications? Where is the role of the anesthesiologist becomes important? There are great deal of hemodynamic fluctuations. There is hypothermia, and then you have to maintain hyperthermia. There is the potential for drug-induced nephrotoxicity, and we have to be very careful with fluids. We have to optimize organ perfusion and prevent this renal injury. Next, please. So traditionally, all the risk assessment of the comorbidities are done. Performance status of the patient is evaluated. Patient and family are counseled that the patient will go to ICU. It's a long surgery, and informed consent, high risk is obtained. So nutrition status is evaluated, especially the albumin levels. Intensive spirometry should start pre-op itself for 3 weeks because these patients are having ascites and pleural effusion, and thromboprophylaxis should be started. So routine monitoring is applied. Invasive monitoring is a must in this case, and you can see the temperatures rising after the installation of the chemotherapy. We go for general anesthesia, thoracic epidural if no contraindication. The point here is that there is a lot of coagulopathy perioperatively, so you have to be very careful when you are putting thoracic epidural. IV induction is done, RSI is done in huge pseudomyxoma peritoneal patient, and volatile anesthesia with opioids are routinely used. Next. Yeah, so here is where the anesthetist has to be very careful. The blood loss, the fluid changes can be 12 ml per kg. There is significant blood loss up to 9 liters. Then there are evaporative losses from abdomen. There are a lot of third space losses. You have to push in crystalloids, colloids, plasma, blood, albumin, everything has to be there. So there are various theories, but better is you have to be goal directed to maintain a systemic and regional perfusion. So, as I told you, maintenance of end organ perfusion is of utmost importance. You have to put in art line, CEP and urinary catheter should be there. Advanced hemodynamic monitoring can also be used. So the incidence of AKI after CRS ranges from 21.3 to 48%, and this may be due to drugs also and may be due to the fluid challenges. So the target is to maintain a urine output of 0.5 ml per kg per hour. During HIPEC phase, you should maintain 2 to 4 ml per kg per hour, and after that 1 to 2 ml per kg per hour should be maintained. Maintain euvolemia in the perioperative period is the key. So as I told you, there can be significant coagulopathy, there may be major blood loss, and there may be other losses like protein loss due to chemotherapy. So it's better to monitor even intra INR, PT and APT. If tech is available, use it, And restrictive transfusion policy is adopted. We don't transfuse below 8 hemoglobin, and sometimes permissive is up to 6. So what is the temperature management? Now these are very challenging things. You have to maintain normothermia is important. During CRS there is a risk of hypothermia because the abdomen is open. But don't go for very aggressive rise of temperature because we have to instill the heated chemotherapy. So another point is during HIPEC then there is a risk of hypothermia to the patient. So during extensive debulking, this can lead to hypothermia. What we do is we warm the fluids in a fluid warmer. We use bare haggers and warming blankets are used, and even room temperature is monitored during this process. So this is the blanket roll by Cincinnati company. This is put under the patient before we start, and during the CRS we maintain the temperature as 38 degrees. So during the HIPEC phase, how we do it? So since there will be heated chemotherapy coming, we decrease the room temperature. We change to now to the cold IV fluids, and this cooling blanket temperature is changed to a lower temperature. We use cold headrest and cold IV fluid bags wrapped in cotton gauge are placed in the axilla and groins. So this is now the same blanket roll temperature is now set at 30 degrees. Next please. So what is the role of regional anesthesia? See, what coverage we need is from T4 downwards. A well-functioning epidural does the job, and definitely this leads to a decreased ball anatomy. So as I told you that exposure of local tissues to high concentration of chemotherapy is there, and anesthetists should be aware of the side effects of the drug use. Normally they will use cisplatin and mitomycin, so their side effects one should be very familiar with. Now this is very important because this is personally, the anesthetist is the only person in the theatre once the HIPEC is going on. So use of chemotherapy carries a potential risk. Use N95 mask, appropriate PPE to all the OT staff, and all these chemotherapy drugs should be carefully disposed of. Next please. So post-operative care, ICU is a must. 40 to 60% patients go to ICU, and any correction of coagulopathy that is required should be done. Fluid status should be monitored carefully, and they require TPM. Next please. So the routine complications are there. There can be anastomotic leakage, venous thromboembolism, or post-operative paralytic ileus, and complications of chemotherapy such as leukopenia. So what are the take-home points? Be vigilant with the fluid management. There are major fluid shifts, temperature changes, increased abdominal pressures. You should be very much aware of whatever coagulopathy is occurring. Use epidural. Knowledge of chemotherapeutic safety is important, and the patients go to post-op ICU where the care of the patient should continue. So today I am standing here in Daman is all because of my head of the department, Dr. Devika J. Shah from Ahmedabad. This is on her 70th birthday when I surprised her from Delhi I came. So I just want to tell the audience this is a very sentimental moment for me today. In 2001, the first Disacon I attended personally was in Daman. I was a resident, first year resident, and thanks to my HOD, she forced me. I didn't have money to register, she got it registered for me. From there I took the stage and I am here in front of you. Thank you. Thanks.